Welcome to the Rocky Mountain MS Center's special webinar series during the time of COVID-19. Today's topic is a COVID-19 update. This presentation features Dr. Enrique Alvarez. Dr. Alvarez is the clinic director at the Rocky Mountain MS Center at the University of Colorado. He's a graduate of the Medical Scientist Training Program at the University of Colorado, Denver, and completed his neurology residency and neuroimmunology fellowship at Washington University in St. Louis. He joined the Rocky Mountain MS Center at University of Colorado in 2013. If you missed something on a slide, we will be archiving this webinar on our website, www.mscenter.org, so you can replay it at any time. We'll reserve some time at the end to answer questions from the audience. You can submit questions at any time by typing them into the chat window on your screen. We will answer as many questions as time allows. Today's presentation is for informational purposes only. It is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Please note we will only be answering questions relating to MS in this webinar. If you have general COVID-19 questions, please visit the CDC website. With that, we'll turn it over to Dr. Alvarez.
Hello, and thanks again for joining us. It is impressive, as I usually find this picture as my starting picture, to be able to look at campus and kind of see how things have changed in just the last few weeks. So the cranes have moved. That I can tell that it's an older picture. That building up front has been done, and now they're working on another one. But one of the biggest things that will not go unnoticed by anybody who's come to our clinic is all the cars out front. Right now, you could probably really park right in front of the entrance. The valets just kind of wave you in. So we've moved a lot of things to telehealth. We'll talk a little bit about some of the telehealth visits that we're doing, how to prep for some of those. But just to kind of be able to give as a follow-up an update on COVID-19 and sort of how our perspective of this is moving along slowly. So I'd like to just start a little bit by kind of showing our latest numbers. So this is coming in from the Public Health Department here in Colorado. These are our state numbers. And one of the things we can see is that the number of cases has stabilized, over the last week and a half, something like that. Actually, they started to kind of maybe decrease a little bit through our state. And I should say that they're not going down. The numbers continue to go up. But as far as kind of the new numbers, how many patients are getting diagnosed each state is going down a little bit. You can see that in this column here, where at one point we were getting an increase of 400 and 300 patients, and we've been down in the 200s over the last 3 days. The number of patients hospitalized is steadying. Sometimes some of these dips that you can see here and here just have to do with weekend numbers and kind of delays in getting reported, which is why there's a little bit of a bump. But you can see that our numbers, again, are indicating that although we have a few more patients getting hospitalized, that overall that increase in number of hospitalizations is going down. That increase in deaths is actually kind of leveling off as well. We had a high of 18 on a Monday, and then it's been sort of low mid-teens. We did have a blip again on Tuesday, and that's going to be par for the course a little bit. So this kind of gives us a sense that across the state, maybe things are starting to level off a little bit. Some of these numbers are a little bit affected by the fact that we've been able to do some more testing, fairly even across the last week and a half or so. At the university level, our total COVID admissions has grown slightly. This is the total number at any one point that's in the hospital, but you can see that starting sort of around April 1st that we've leveled off pretty well. Because some of the patients that get really sick end up having to be in the ICU, these patients take a little bit of a longer time to recover from these infections, so they can stay there for a while. So these patients tend to accumulate a little bit at the ICU. And again, we can see that even despite of that the numbers are going up, but very slowly so at this point. We've been looking at different models, and there's none of these models are ever perfect. Only when we start looking back and we really see what the numbers are. This is one of the models that's been used some. It comes from the University of Washington, which many people may know was one of the hotbeds early on in the U.S. I would say these models are often wrong, and especially very early on, they are often wrong. But the concerns that we were having, I think, are very well illustrated. So this model was a model that was done on April 1st. And it was predicting that our peak of cases would be around April 17th. And what it shows are various curves. So you can see here a curve showing the number of hospitalizations. We're kind of around here. And we can see that these numbers were starting to kind of really increase. One of the indications this model was wrong is we started to see some of the levels kind of level off and not increase exponentially, but a little bit more linearly and kind of start going like this. But the number was scary because this line here, horizontally around 5K or 5,000, was the number of available beds available in the state of Colorado. So it's just under 5,000. We can see that here. And it was predicting that we were going to need 6,776 beds. So we were going to be nearly 2,000 beds short in the hospitals. If that wasn't bad enough, the other thing that we were seeing under these lower curves were the issues around ICU beds. So this bar represents the number of ICU beds, and we could see that the number of patients needing ICU beds was going to be much higher than what we actually had, and those patients needing intubation was still going to be higher than what we had available in the state. So if we have about 554 ICU beds available, then we could see we were going to be almost about 500 beds short. So these were what prompted so much action in the early days and why we're all hunkering down at home as much as we can. Well, the idea was to try and level this out and spread things out over a longer period of time. Let me present, I hinted that the numbers started to look better, so I'm superimposed here. This is the old graph, but superimposed here is the new numbers. So this was the model from yesterday from the same group, and we can see that of the 5,000 beds available, that we were probably only going to need about 1,100 or 1,200 beds. Out of the 550 ICU beds, we were only going to need 200. So we've managed, it looks like, to kind of flatten out that curve, and this model doesn't show it necessarily extending out, but some of the models do that. Because we're not sure and it's predicting, you have sort of these gray areas that says, hey, the numbers could be anywhere in that range. Well, the models assume certain things, and part of the social distancing came in after some of that April 1 model, and so we could see that we got out of that shaded area. Let's look at it a little bit easier without that superimposed. So this is kind of our new model here. And so we could see that the number of ICU beds looks like we should be okay. The other thing I mentioned is a lot of the hospitals have done a lot of things to try and increase the number of ICU beds available. So one of the things that they were doing was reducing the number of elective surgeries, pushing those out so that patients that sometimes needed to stay in an ICU bed for a day or two after a surgery, for example, would free up those beds in case they were needed. And some of that anticipation, our hospital has been about as empty as it gets. They also converted some of the operating rooms into ICU units themselves and things like this. The number of beds available has increased from this point. I can tell you this model increased a little bit compared to yesterday. So these are moving targets just based on sort of the latest information. But as of now, it's looking like things might be a little bit better as far as when things might come to an end. If we believe this model, we can see that maybe by May 1st, things may quiet down. I can tell you a little bit about the model that's being looked at within the state of Colorado. It's a different model from this. It looks very, very different. Unfortunately, it doesn't look as pretty and doesn't quite have as much information. And so that's why I'm not showing a picture of that. It's actually extending some of these numbers out more into June and July. And it's a little bit higher than this still. But again, we'll have to see over the next week or two. I think we'll get a much better sense as to which model we can probably follow a little bit better. And so just because this is starting to show at May 1st, it doesn't necessarily mean that the world will become normal again on May 1st, and we'll have to kind of keep an eye on things. So the good news, again, from these slides is that it looks like things are maybe slowing down a little bit. We have to worry about, more cases coming up, and there's a concern that in the fall, we may start to see other blips coming up. All right, so what can we learn from other countries? So I put on my high heels and I joined a call for international women that get together. But in some of these other countries, a lot of these repositories were actually being led by women. They invited us guys to join in last week, Wednesday. And so we got a really good sense as to what's happening in some other countries. One of the leading MSologists in Italy presented their numbers, and they had over 60 confirmed cases of MS patients who developed COVID. There was about another 80 cases of suspected cases. If we think that testing is bad here, it sounds like testing there is really bad. And so that's why there's so many of the suspected cases still there and not listed as confirmed. Unless you were getting intubated or having really bad disease, you were not getting tested. Those numbers, if you kind of figure about 140 patients, if you look at sort of the proportion of patients that are confirmed or suspected for all of Italy, looks about what you would expect for MS patients in the general population. So it's suggesting that the patients in Italy with MS aren't getting COVID any more frequently than the average fare coming in through clinic. They reported 5 deaths as of last week. Interestingly, 3 of them were not on any treatment, on any disease-modifying therapy. One of the patients was on rituximab. One of the patients was on Tecfidera. They had a number of patients develop disease on any of the other type of medications. The youngest patient to die was 54, and that's showing a little bit about the effect on age on these patients, and I'll show more of that a little bit later. The other thing with MS that we worry about is the treatments and the effect they have on the immune system. And so if some of these medications lower the immune system, one of the things we can measure for that is lymphocytes. Lymphocytes are a type of white blood cell. The lymphocytes can then be divided further into B cells and T cells. So B cell therapies, rituximab and ocrelizumab, take out part of the lymphocytes. But things like Tecfidera and Gilenya will decrease lymphocytes as well. And so they noticed that 12 of their patients had low lymphocytes, and these did not appear to do any worse than the patients who did not have low lymphocytes. Meaning that it looks like one thing that's happening is that these patients are not at increased risk of having bad disease. All right, what other things can we learn from other patients? So from Spain, they had 32 patients and 1 death. It was a patient on natalizumab. The interesting thing about natalizumab or Tysabri is that this is a drug that some experts in the field have suggested that we switch patients to. Again, this is one patient, so it's hard to draw any conclusions that it's good or bad. But it suggests that patients on natalizumab, like any other medicine, can pass as well. There were some concerns. I heard some reports that some of this was maybe associated with an inability of that patient to be able to get into an ICU because their ICUs were full in that part of Spain. And so that's the concern at this point for a lot of this. In France, they reported 30 patients. France was a little bit slower than Spain and Italy in developing cases of COVID, but they already had 30 patients and no deaths. Interestingly, 2 very sick patients were fairly on the young side compared to what we're hearing in most parts of Europe, with these patients being 25 and 31. Again, most patients are usually over the age of 60 that we're hearing having bad outcomes. There is also an international effort, mostly that started European, but it has now included groups such as in New York called the LEOSS group of repositories. And this was not MS specific, but if you collect enough information, and this was a huge bank, they had 281 MS patients, and in that group, they had 5 deaths, and all of them were on different drugs. So no 2 patients were on the same drug in that group. So again, the number of patients with MS doesn't seem to be increased who develop COVID, and the severity of the cases don't appear to be different. And I think the reassuring part about this slide is, to some extent, is that we have enough cases recorded of people developing COVID with MS on different drugs to kind of get a sense that this probably is an accurate statement, although, of course, the more data you have, the more comfortable you'll feel making that statement. If we look at what efforts are being done in North America, there is a North American COVID repository. This is being led by my former mentor, Ann Cross, at Washington University in St. Louis, and it's funded by the National MS Society. They're asking that patients do not get reported for 7 days after symptoms start to improve to allow to collect outcomes. So if you report a patient right away, then it doesn't allow you to say, how's that patient doing afterwards? So the idea is to kind of give it some time for patients who start recovering to kind of get a sense for, is there improvement, or the patient's going to die, what's happening with that person. The information is going to be de-identified. It is going to be specific to MS and then NMO spectrum disease, including the NMO patients and MOG patients. And the patients can be either confirmed or suspected, similar to what we saw in some of the other repositories in Europe. Certain parts of the country have a lot of testing, and certain parts of the country don't have a lot of testing. So this should allow us to get a better sense of what the experience is in North America. So what are the risks of bad outcomes in MS patients? These numbers got split a little bit here in the slide, but basically you could see that for different group ages, as you look from left to right, as patients get older, the top bar, the really dark blue, the number of deaths starts to be a larger chunk of that. So as you start to get into the 50 to 59, there's 1%, less than 1% below that. In the 60 to 69, it's 2%. In the 70s, it's 9%. If you get into the 80s, you start to look at 24%. So age is a huge factor. It looks like probably by itself, although a lot of things tend to get worse as we get older, including developing other comorbidities. So if we look at that, for example, we could see out of a couple of big studies, what are some of the comorbidities, other medical conditions that patients can have that make it more risky. So we get this report out of China, over 1,000 patients that died, and looking at sort of what were the risks of having other things. In other words, what percent of those patients who died had a certain comorbidity? And we could see that cardiovascular disease, particularly like ischemic heart disease, was a big one. This virus, unlike a lot of the other coronaviruses, the viruses that tend to cause the common cold, can directly infect heart tissue. And so that is one concern regarding this. 7% of patients who died had diabetes, 6% respiratory disease, 6% hypertension, 6% cancer. Less than 1% of patients did not have comorbidities. I bring up the issue of cancer because this is where we get a lot of our concern for immunosuppression, in the sense that we're seeing that some of these patients do have a higher rate of dying from COVID. Now, what I would mention is that a lot of times we talk about immunosuppression from conditions like cancer, where we use really big guns to go after those cancer cells. What we're getting the impression is that MS patients are on chemo light or kind of lighter forms of immunosuppression, since we're not seeing these big increases in MS patients. Out of a group from Italy, 355 deaths, what percent of those patients had different comorbidities? So here, ischemic heart disease was 30%, 20% diabetes, 20% cancer, 7% atrial fibrillation, stroke, dementia in that group. If you look at it, on average, a patient had 2.7 comorbidities, and again, less than 1% of patients had no comorbidities. So that gives us a sense of what to look out for that makes us a little bit more at risk. And again, in the U.S., 94% of patients had at least one comorbidity in a little bit more of a smallish type study. So this gives us a sense for what are the risk factors as we look at. I'll pause maybe a little bit later. Let me get into some of the tips as to how we're working to try and do telehealth visits and the main goal for a lot of this, again, is to try and reduce the contact with healthcare providers. I think one of the things that came out fairly early on in Italy is that it looked like COVID was getting spread by contact with the hospitals, providers getting sick before they knew that this was coming, not wearing the right protection and things like this, passing it on to the patients as they came in for their visits. So all of these things, I think, are helping to kind of reduce the risks. So what are telehealth visits? So basically, if you want to think about it as Skype visits, that's kind of what it is. I think these work really well, and we started to kind of ramp these up a fair amount. As a whole department, we got up to something like 90 visits in January. Now we're doing like 120 just in neurology a day. So obviously there's been a huge ramp up over the last few weeks. As a hospital system, we're doing something I'm hearing in the order of 4,500 visits a day. So very much emptying out the parking lots, as I mentioned at the beginning. So how does it work? You have to log into your account through My Health Connection. You can go through the app or through the website. You want to make sure that everything's kind of set up. What we want to make sure is that you have sort of a good enough connection that you can look at movies with that connection. So if you can download video, that tends to work really pretty well. 2 days prior to that My Health Connection, you want to start the check-in process, and you have to sign a consent basically saying you're willing to get treated via telehealth. It's not any different from the consent you sign just of becoming a patient when you come to the clinic for the first time. The big push is we try to get as many records as we can. So if you're a new patient and we don't have much for you, your first appointment is going to be a little bit of collecting some of the history without being able to get into a lot of what your MRI looks like. We tend to be okay at getting paper records, so paper descriptions of kind of what the MRI looks like. For most brain MRIs, that's not sufficient. A lot of details around the size of the lesions, where the lesions are, what shape they have, things like this are the things that we use to try and diagnose MS. Try to see if it looks like an MS lesion or not an MS lesion, because other things can pop up in patients who have MS. And so because of that, we really try and, see if we can get as much of the records if you can send stuff in. And that includes the MRI scans, so not just the paper records, but the scans if possible. And that's our fax number to the clinic if you want to send things in. So you're logged in, you got everything set up. On the day of the visit, we want you to be available usually 10 or 15 minutes. We have a little bit more time for some of these visits, and so they tend to go kind of fast too. If you're ready, we usually can kind of get you in a little bit earlier in your appointment, depending on where you're at. The MAs will reach out to you. Make sure that things are working, speakers, microphones, the computer software, that everything's updated and things like this. A few tips are to try and use a computer webcam. They just tend to give you a little bit better resolution than some of the phones. Also, if you have a phone, you just tend to move it a little bit, and that causes a little bit of motion that makes it, it can make things a little bit blurrier. Chrome and Firefox work a little bit better. And again, if you are at home and have Wi-Fi, it's better to go through Wi-Fi than than just a telephone line if possible as well. The other thing too is that a lot of things can slow connections down. So if your kids are playing games or somebody else is streaming a movie, that's going to compete with some of the bandwidth at home to be able to do the televisits. And so it'd be good to try and reduce how many other people are on the webcam to try and improve the quality of the visit. The other thing then is you want sort of a quiet environment to be able to do the visit. If there's a lot of background noise, it's going to be hard to hear. You try and avoid sort of having a light behind you. That just makes you dark in the front and harder to see details such as, is your face moving? Are you moving your eyebrows? It may not be very clear a lot of times. You know, I often get the question as to, you're not going to do an exam on me today or something like that. But we're really doing an exam throughout the entire visit. When you're talking to us, we're trying to see, are you moving your hands? Are you using your hands? Are you getting a tremor? Is your face moving the way we would expect it to? And things like that. And so we can get a lot of sense for disability just while we're talking with patients. So if you have a light in front of you, we can actually look at eye movements really well. We can ask you to do certain things on the camera. We might ask you to get closer to the camera, stand farther away from the camera, and that's, again, works a little bit easier on a laptop than on a phone. Assume that there's going to be a lag. Sometimes it's easier to kind of start over talking, but if you kind of say something, pause, let the other person kind of go, let them pause for a little bit, and then kind of jump in. It's a little bit slower, but it kind of helps things run a little bit smoother. And then just make sure we try and still put in sort of an after-visit summary, and that gets put out electronically once we finish our notes, sort of what we need to do, MRIs, labs, and things like this. This is a great point then to kind of start talking a little bit about what is the clinic doing, what are our suggestions. They're not that different from what I mentioned maybe last week whenever we did our first webinar. For most patients, we're still recommending that they continue with treatment, that most treatments, like Desavri and Gilenya particularly, can be concerning if you stop them all of a sudden, because there can be a rebound of disease activity. Disease can reactivate after certain periods of time. With T-cell therapies, we are trying to push those out a few months thinking that that's how long things will be shut down a little bit. We know from how effective the drugs are that they probably work longer than more than just 6 months, and so that's why we're pushing those drugs out for that couple of months. Things that are MRIs, labs that are routine, so just kind of checking. There was no concern of any abnormalities in the past. Those we're trying to push out as well. If your labs look a little bit funky and we're trying to kind of follow up on things, we want you to have those labs drawn still, and all the labs are still open, the clinics are still open. If we need to do MRIs, we're still getting MRIs done. We're actually getting MRIs done a little bit faster than usual because, again, so many things have been pushed out. But everything's kind of getting cleaned out more than before, so it's not as fast as it used to be. And I think starting to think about where we're at in things, and as we start to kind of get back into some sense of normal, trying to kind of get a sense for, can we still do things as before, and everything might get pushed out a little bit. So even though your infusion maybe is not due till June, you might get pushed out a little bit, even if it's normal, because everybody from end of March, April, May might have gotten pushed out, and the system just can't handle things right away. But I think by pushing things out for one cycle or something like that will allow us to continue to treat everybody. We have extra capacity now to do a lot of infusions and MRIs and things like that. And so I think things will still happen as normal here in the near future. And again, things that need to be done are still being done. The nurses are still answering the phones. We're still doing visits and continue to do that. So with that, we'll turn it into kind of the question part of the webinar. And we can see what kind of questions are coming in, Kelsey, if you want to start relaying some of those.
Yeah, thank you, Dr. Alvarez. If you do have a question to submit, please do so now using the chat window on your screen. Again, we're unable to give out specific medical advice. If you have questions relating to your specific treatment plan, please discuss those with your neurologist. I encourage you to check out the COVID-19 education page on mscenter.org. The web address is on your screen now. There you will find Dr. Alvarez's first webinar with COVID information, a webinar featuring licensed clinical social worker Alyssa Berlinger discussing how to manage mental health during times of uncertainty, these telehealth tips, and a resource guide that includes links for everything from COVID information, food and supply resources, mental and physical health links, and a wide variety of fun and unique entertainment activities that are pretty much all free. So as we go through these questions, we have had an awful lot of questions come through, and a lot of them are very similar in manner, so I will be grouping similar questions together so that we can cover as many topics as possible. First, Dr. Alvarez, I'm going to ask a couple of questions that might be clinic specific. Do you know if infusions are being automatically rescheduled, or should people be calling to check in?
Yeah, so it depends a little bit on the infusion center. Through AMC, so at the Anschutz Medical Center, our patients are getting contacted to push things out. I believe some of the Lone Tree and Memorial Health patients are getting pushed out some as well. You know, in these times where things are getting busy, just kind of assume that you have to be a little bit more on top of things. And so it's not a bad thought to kind of stay on top of things and be proactive about pushing things out, especially if you're due for an infusion soon. It's good just to kind of reach out and kind of get your place in line a couple months from now and see where things are at. So I try and be proactive and reach out. There's a lot of other infusion centers that we're sending patients to just because of geography, sometimes because of our expenses through the hospital and insurance reasons. We're pushing, again, patients to other infusion centers, and so not all of them may be kind of thinking ahead and rescheduling things. And again, that applies to the B-cell therapies.
Can the Rocky Mountain MS Center doctors see people out of state via telehealth right now?
Yeah, that's a challenging one. So things have been loosened up. There's a concern from the School of Medicine around some of the malpractice insurance, and some of those things haven't been loosened up that much. So for certain states, we've gotten permission to see return patients. We can see patients as of at least yesterday that were returns in Wyoming and Idaho. For other states, it's harder. For new patients, we're still a little bit limited, and so our strategy for doing some of this is we can reach out to either local primary care doctors and provide consultations with them. We can reach out to specialists, either neurologists or other specialists that are closer to the patient in their home to come up with treatment strategies and things like that. So we're still doing a lot of that, but yeah, out of state has gotten a little bit harder. Well, not gotten. It's always been a little bit harder. We always need to come to us. So we're trying to ease things up, but it's not opened up as much as we'd like it to. One of the things I should mention is one of the things we can get around with this, and this always seems like cheating the system a little bit, is being in state doesn't necessarily mean being in Denver. So we've done televisits for patients from other states who have simply just driven across the state border, pulled off the side of the interstate, and had a telehealth visit. So we can get creative sometimes.
This may be more of an insurance-specific question, but have you heard any relaxing? This person had a telehealth MS visit in January and was told that they couldn't have another one this year. Have you heard of insurance companies kind of relaxing on that at all for COVID-specific stuff?
They've relaxed a lot as far as that goes. I had not heard about the limit of just being able to do one telehealth visit per year. but I would check with the insurance and verify to see, because for the most part, insurance companies have actually been really good about letting us do as much as we can via tele.
Alrighty, so I'm going to move into kind of a general COVID-MS question category. Just generally speaking, from the numbers that you were seeing in other countries and such, is there a risk for more severe disease, or just a general increased risk of contracting COVID-19 because of MS?
Yeah, because of MS, the numbers from each one of these experiences has really been that there's not an increased risk for having MS. From an MS perspective, we don't expect that MS patients are at higher risk of developing infections by just having MS. I mean, the one exception there would be if you have problems breathing, it's more likely you can aspirate. You may not be able to empty out your bladder and have urinary tract infections. But things specific to COVID, we would not expect that MS patients would have that risk. The real risk that we were a little bit concerned about was whether or not patients were on immunosuppressive treatments. And we're not seeing that by being on those treatments, even if those treatments are decreasing your counts of white blood cells, that puts you at extra risk. I should mention one thing real quick too. So off of the COVID infection, there's probably two phases to the disease if you want to think about it. There's the part that's the common cold, kind of the runny nose. There's a little bit of less of that with this type of coronavirus. It seems like this is less of what they call an upper respiratory infection and a little bit more of a lower respiratory infection, meaning it tends to get into the lungs much more than the other coronaviruses or the other common colds. I forgot where I was going, sorry. Got distracted, sorry. Kids walking in front asking for questions. I apologize for that.
Do you think that having MS as a pre-existing medical condition would make someone more of a candidate for the COVID test? Do you recommend them pushing to be tested, particularly before an infusion?
Perfect question. As of yesterday, they now got included into the group of patients that should be getting tested. So in the past, it was pretty much restricted to healthcare providers for the fear of continuing to spread it to other patients, and then as well for patients who were hospitalized. We can now start testing patients that are not hospitalized as long as they're on immunosuppressive therapy. So most of our MS patients would qualify for that as long as they're still symptomatic. So you still have to have some concern for symptoms. You still need a doctor's orders to do that testing. And then we have to actually send you to specific labs, is my understanding. But again, this is rapidly evolving as they just literally opened this up yesterday as a state guideline. And so the two sites that I heard about this morning that can do that testing for us is the Anshu's Outpatient Pavilion lab on the main floor, as well as at Smoky Hills. And honestly, I tried to Google that site before and I couldn't pop it up. There's a couple of different UCH facilities there. And so if it comes to that, ask the providers, the nurses, or call the main line to the hospital for information about that. Oh, I know what I was saying before. Sorry, things are slow to come back. So the two phases to the disease. Sorry about that. So there's the initial phase, so the cold part of it, and that's where the antivirals are probably the most helpful. We don't have much of that. I would really probably dissuade against any thought of trying to use hydroxychloroquine or any of these other therapies that have really been pushed out. And then there's a second phase about the inflammation that happens. So most of the patients that end up intubated, it's not from COVID directly, it's because they start developing enough lung injury because of the immune response gets too exaggerated. And so actually immunosuppressive drugs at that point have been used and seem to be helpful at that point. So steroids have been used in China. There's a trial with Gilenya as a treatment for COVID for those patients. And one of the ones that's a little bit more promising is anti-IL-6 therapy, interleukin-6 therapy. We don't use that in MS. We use it for other related conditions such as neuromyelitis optica. We have a handful of patients on that treatment. And so depending on where things are at, you kind of want to think about it at different stages, a little bit kind of like MS. You got your relapses and your progression, and you kind of target things a little bit differently. All right, sorry about that, Kelsey.
No worries. You mentioned pediatric fluorescein. Can you just speak a little bit to that as well?
Yes, sure. So there's been a lot of drugs that are being repurposed for trying to kind of think about whether it might be helpful. There was a study out of France that suggested that hydroxychloroquine, which is a rheumatology type medicine, was maybe helpful in treating COVID. The benefit kind of was when you added an antibiotic to it called azithromycin, and the combination seemed to be impressively helpful. I would point out that it was only 20 patients, that a number of those patients still did not do very well in that study. There was no comparator group, so it's possible that none of those patients would have died and the drug was maybe actually hurtful. So the issue is we just don't know. A couple of things I would point out. The thought as to why they tried it was because they looked at the virus infecting cells in a petri dish in the lab. You can put a lot of drug into a petri plate, and so then the concentrations of the drug that you need to stop the virus in the lab is about 10-fold higher than what you usually use in person. And that would not be good to try and get those kind of levels into human beings because they're toxic. So it seems like at the dose that we normally use that it may not necessarily be very helpful. We also know from these repositories, we're not the only one trying to collect this data, so the rheumatologists are doing similar things, and because it's a rheumatology drug, in their repositories, about a quarter of the patients were on that drug. So even if you started the drug, it seems like when you got exposed, you still developed the infection, and you still ended up getting COVID-19 type symptoms to the same kind of severity as what everybody else was getting. So I am not very excited about it. I would stay away from thinking that this is sort of our golden ticket and that it's going to do anything. I think it's important to do the trials and see if it's helpful for this. The other drug that people might have heard about is remdesivir, which is something that was looked at, I believe, for Ebola. And again, the concentrations needed for some of these antivirals was on the order of 10-fold higher than what we can really reach in bloodstream. So a little bit of word of caution of kind of these types of medicines, and it's probably going to require something specific to this virus. Science moves a lot faster now than it did in the past. I think things will come out, but it may not help us in the next, several months. And hopefully the virus dies out, but if it becomes kind of our common everyday type virus, I'm sure we can develop something really pretty fast against it if needed, including vaccines and those kinds of things.
I've got a couple of different questions about kind of social distancing guidelines in specific situations, so I'll give them all to you. Do people need to be careful about seeing their grown children and grandchildren? Is 6 feet away a good distance to consider, or should we not be seeing them at all? Particularly for treatments, if people choose to continue their infusion treatments, what are some precautions they should be taking when they go into the infusion center? And then also, are things like PT, dry needling PT, what kind of precautions should people be thinking about?
Yeah, so that's perfect. So part of the reason I spent the amount of time I did looking at comorbidities is to try and get a sense for putting yourself into a risk group. My dad, I think, fits all those risks. So he turned 80 in January. He's got heart failure. He has COPD, he's got diabetes, uncontrolled blood pressure. I would not bet on my dad doing very well if he developed COVID. So my instructions to my dad were stay locked up in the basement, don't leave the house, get your groceries, from somebody else dropping them off, and just really try to hunker down as much as possible. The idea for younger people is to try and do similar things to try and help spread the virus to other people. But if we all hunker down, then we get into these issues of who would do the groceries, who would take care of those people that are sick, who's going to make the masks, and those kinds of things. In the clinic, I can tell you the approach we took was to try and say, hey, for the younger people, let's try and do the in-person visits, and maybe for some of the providers that are a little bit older, the support staff a little bit older that have other conditions, maybe are taking immunosuppressive drugs themselves, let's try and get you out and seeing patients as a first-line step. And so I think that hopefully helps answer some of those questions in the sense of if you're kind of in a low-risk group, trying to, not necessarily do all the same social activities as you normally do, but to try and at least, kind of still socialize a little bit here and there. And, again, being careful about hand washing and things like this. One of the things I heard about were, for example, parties where, people would come, one group would come in through the front door, another person through the back door, and they kind of sit on one side of the table as opposed to the other side of the table so that they're facing each other, kind of not necessarily doing handshakes. So I think there's ways for people to kind of still be around each other that don't necessarily have to increase risks for the people meeting. The idea of 6 feet is not arbitrary. The reason why that is because we think that the virus is mostly spread in droplets. So this is the gross notion that every time we speak, we spittle a little bit, and those droplets get, into the air. And if you breathe those droplets of saliva from somebody else, that's how you get the virus. Because they're droplets and it's not like they're floating in the air, that those droplets will tend to fall because of gravity to the ground. And on average, about 6 feet allows most of those droplets to kind of fall to the ground and not necessarily spray across the room. So I'm glad we all had lunch just recently and thinking about that. But at least it gives us a sense as to why these numbers are kind of coming in through. And so if the things to think about is that it looks like the virus probably stays alive on hard surfaces longer, maybe 3 days, versus on cardboard, maybe only a day. So things like doorknobs are, I would, think about them as sort of being dirty surfaces. And that would be the kind of stuff you really don't want to touch. You also have to think about masks. Masks are less to help protect you, but the thought is to help protect others. So if you are sick and you wear a mask, that mask will catch your droplets and help it from getting spread to other people. Where we get in trouble is if the person that's sick is not wearing a mask and they, leave some droplets or touch a doorknob, you touch that doorknob, and even though you're wearing a mask, maybe you then kind of want to scratch your eye or something like this, then it didn't really help too much. So I think it's thinking about those things and trying to kind of clean those commonly used, what we call high throughput touch areas, places that we touch a lot in the household or at work or things like this. And those are the areas that should be cleaned very frequently because that's the area where the viruses are much more likely to get spread. Sorry, that was a long-winded answer, but I hope that kind of explains a little bit of the rationale for some of the guidelines.
And then do you have anything specific for hospital visits if people are going in, particularly like for Tysabri, which we're not recommending you push out?
Yeah, with Tysabri, the concern of rebound, so we would want people to come into the hospital. Again, it's trying to minimize touching doorknobs and things like this. The hospitals are doing a really good job of cleaning all these areas, much more so than they did in the past even. There's a lot more care to doing that. Because we've reduced the volume of people coming in through the hospital so much, you will not recognize the facilities at this point. I literally parked in the front visitor, not even the parking lot of our clinic. You could park where the valet is at. Open slots everywhere. And so it's almost like social distancing in the clinic to some extent. So I think those are the things, because you need to do that, you want to do that, and you just want to do it carefully, being extra careful about washing your hands, and those kinds of things.
We've had a lot of questions come in kind of about if somebody with MS contracts COVID-19, questions like, is the treatment the same? Do I need to say anything specific to doctors and nurses to identify my condition, or to let them know that something needs to be done differently? If I'm not feeling ill enough to go to the hospital, do I need to think differently about it than someone without MS? Kind of that thought process.
Yeah. So, to some extent, the process hasn't changed much, because our general guidelines are is we usually don't want to infuse you if you're feeling sick. Now, usually we say that, small urinary tract infection or things like this, but we've always kind of fallen hard on the line of, like, especially with a fever or kind of, short of breath or those kinds of symptoms, we never want to infuse you in those kind of conditions. So obviously, if you're sick, we would hold off on infusions. We know that we can extend Tysabri. One of my thoughts for staying at sort of a 4-week cycle, if possible, is that if you do get sick, or if and it may not need be with COVID, but maybe it's just with the common cold. There's a bunch of flu A that's still kind of floating around, and those kinds of things. If you get sick, that gives you a couple of weeks to kind of get past it and then come in for the infusion and be fine. Most patients can be pushed out to 8 weeks, so I think it gives us a lot of flexibility for that. But trying to kind of stay at the front end should something happen can be helpful from that perspective. And so that's kind of why those guidelines have kind of stayed around where they're at.
The next group of questions is kind of about the possible vaccine or treatment that is being developed for COVID. They're looking at malaria-type drugs. Do you have any thoughts on just MS patients and whether or not they should receive a vaccine when it becomes available, or if the malaria-type drugs are considered safe for patients with MS?
Yeah, the malaria drugs are the drugs we were kind of talking a little bit about with the hydroxychloroquine, and so very similar in that kind of thought. At this point, if you get sick and you're being offered a clinical trial, to me, to some extent, it might make sense to kind of consider it, but I wouldn't start taking drugs if it's not from a trial. Remember, we do trials because these drugs have the chance of being hurtful as much as that they're helpful. And so trying to be careful about that. If you're not going to a malaria-type country, we don't have you on those drugs because of those concerns. So holding back in that situation, I think, becomes important. As far as vaccine goes, some of the recommendations may vary depending on what kind of vaccine gets developed. So a lot of the vaccines that I've been hearing about are things like antisense DNA, or really RNA, with the idea of so this is an RNA virus that's a single strand. If you put something that matches it in the opposite direction, it's kind of like it helps block the DNA of that virus so that it can't multiply very well. And so something like that should be fairly safe with MS and in our treatments. We are usually really okay with vaccines that are dead. So as long as it doesn't involve taking some of the virus and just kind of making it a little bit weaker, we are okay with any sort of version of dead vaccines and things like this. One of the things that we know is that not all vaccines are 100%, so keeping that in mind. The flu vaccine varies from year to year. Some years it can be down into the 50s and 60% effective, and some years it can be 90% effective. So depending on where we are at from a vaccine perspective, it may or may not be helpful, and we want to be able to give us as much flexibility, get a sense for that, and that's where the trials are important to know where things kind of come out from it, as far as outcomes, as far as side effects and things like that. One of the things from the treatments, just to take a few seconds, I think it was coming up as one of the questions, was this convalescent plasma concept. And so that's the idea of taking blood from patients who have recovered from the disease, and then getting some of that with the idea that you would get some protective antibodies from somebody that's already mounted an immunity to that virus. It's something that's being tried. I know of actually one MS patient in our university who has received that. Unfortunately, that's one patient that there's intubation, and then there's something that's even more drastic than that called ECMO. And there's a patient on ECMO who is getting that sort of treatment. Whether it's effective or not, and how much of being able to fight this virus is mediated by antibodies versus having to get, other types of immune responses. Remember, the immune system has many different components to it. If you want to think about it as sort of a military force, if you take out the Army and leave the Air Force and Navy for certain conditions, that's more than plenty to kind of take out the enemy. But it may not be enough in certain other situations. And so I think that's the part that we don't know yet about this disease, but it's something that's being looked at and getting worked on. So I think we'll get there, and we'll have probably a lot more information in a few, probably weeks to months. The other concern a little bit is in Colorado, we've not had that many people yet kind of fully recover from the virus. Patients even in the first wave are still, only a couple of weeks really past. It seems like it's been for forever, but, some of the early patients were still only a few weeks out. And so trying to get a sense for how much blood can they give, how much of this blood would you need to try and protect somebody else, to treat somebody else, are things that we still don't know really well.
I know we're getting close to the end of our time, but I have two more question groups for you. And we keep kind of coming back to the DMT questions. It is the majority of the questions that we got, so I'm going to kind of delve a little deeper into them. Can you kind of discuss the difference between immunosuppressant and an immunomodulator, and kind of what that means for COVID? Specifically, we've had questions on Tecfidera, Gilenya, Aubagio, and Copaxone, and then save Ocrevus and rituximab. I have a whole slew of questions for those.
All right. So the technical difference between immunomodulator and immunosuppressive is immunosuppressive is something that lowers the immune system. Immunomodulators are medicines that modify the immune system. It sounds like that would be really easy to define and gauge at the clinic level, but it's maybe not that easy. Immunosuppression is something that is a little bit of a dirty word. Nobody wants to be on an immunosuppressive. Everybody wants to be on something that just kind of changes the immune system to something that works better. And so most drug companies will use the word immunomodulator for their drugs. There's certain times where drugs are clearly immunosuppressive. If you're going through full-on chemo for cancer and things like this, and your white counts are down to 0 and things like this, that's very clearly a change in the immune system. So you could still say that that's an immunomodulator, but it's modulating it by decreasing the immune system. At the opposite end of things, you do have medicines like Copaxone and interferons that I don't think anybody's really going to say that they lower the immune system, but they may modify the immune system, and that's how they work. or they do modify the immune system, and that's how they work. I would point out that certain drugs like the interferons and Aubagio, and maybe in that category, have been touted to have some antiviral properties themselves, and so why not use it for this? Remember, viruses are not just one virus. They all work very different. So just because you show some effect against one virus doesn't mean it works for all viruses. So I would caution a little bit about switching everybody to interferons and to Aubagio because of their antiviral effects. I think that remains a little bit to be proven, and maybe not necessarily the right treatment option for a lot of patients if they still need to treat their MS. And so I think it's balancing those things. In the middle group, if you start to think about, for efficacy, if you start to think about the fumarate, so Tecfidera and Vumerity, if you think about the S1P drugs, Gilenya, Siponimod. Last week we had Ozanimod get approved. They delayed launching because of COVID. But because of those drugs, they may not be immunosuppressive in most people. So Tecfidera might be a perfect example of this. We know that 2% of patients will have lymphocyte counts that drop below sort of a magic number for us of 500. I think in those patients we would say that the drug is immunosuppressive, and that puts them at higher risk for certain types of infections. But for a lot of other patients, the white counts stay within the normal range or slightly decreased, and so they may not be that immunosuppressive. So overall, it depends a little bit on where your labs are, where your response has been to that drug, where I would say that that's maybe more on the immunosuppressive spectrum than maybe an immunomodulatory spectrum type of drugs. And that's a little bit of the reference that if your labs are not, you're having close monitoring of your labs because your white counts maybe are a little bit borderline, maybe your livers were a little bit high. Those are the patients we still want to come in and still have labs drawn. We can still do the visit via maybe tele, but then have the labs. We've not figured out how to do the labs via tele, so we still need to do some of the stuff in person. So hopefully that answers a little bit of that question. For some of the patients whose Gilenya, who were on Gilenya, for example, and had white counts that were borderline, I've done this on 1 or 2 patients, was take them and do the dosing every other day because it has a really long half-life and the drug probably can work a little bit longer than every day. And so sometimes that's a way to kind of reduce the dose a little bit but not reduce it a lot. So there's some strategies that we can do sometimes in these borderline cases, but for the most part, we want people to do the drugs that at a level that we know that the drugs are effective, because otherwise then you might get the side effects of the drug and not really get much benefit from an MS perspective. And remember, COVID is scary, but so is MS. So we want to be able to kind of take care of and find the right balance between those two risks. And then I think you wanted to ask about infusions.
Yeah, so my final question I think can best be answered by kind of walking us through a timeline of the of Ocrevus and rituximab. So if people get an infusion, do they need to be worried right after the infusion? Are they more susceptible to things? How long can they push an infusion out? Are there rebound effects? Just kind of going through that whole timeline of a rituximab or Ocrevus infusion.
Yeah. So usually we tend to think of the drugs as having a direct effect, right? So if you take a drug, it takes a little bit of time to build up in your system. Once it's built up in your system, within each cycle, maybe it wears off until you take another dose and things like that. For most drugs, the pills and things like this, that's very, very much the way to think about it. Tisabri is that way. The B cells, the drug does that. So you'd get a rituximab infusion, you have high levels of rituximab, and then the drug washes out. Surprisingly, some people may be curious to find out that the drug really washes out within probably 2 months, 3 months. The half-life is about 20 days. If you do about 5 half-lives, you get into really little drug being left. So there's not much drug left towards the end of the cycle. So then you say, well, why are we only dosing it every 6 months? We should probably be dosing it every 3 months. That has to do because the effect is you deplete the B cells. That happens pretty much immediately. So even in the middle of the infusion, you can probably look at B cells, and we have, and you have no B cells left. And then those B cells take some time to recover, and that can take anywhere from 4 months to 2 years. But on average, it's about 9 months. So depending on what you're kind of going after from a treatment perspective, we know that we can kind of spread things out, that it doesn't really matter too much, where you are in the cycle from an immunosuppression perspective. The number of B cells for most people is 0 right after the infusion and 0 right before their next infusion. And the reason to keep those cycles down to 6 months is a little bit of following those B cells. In the early days from rituximab, there was the very first study involved doing 1 infusion and then waiting a year. And what we saw was that only 1 patient really developed a lesion, I believe, around month 9. Otherwise, everybody was pretty well controlled. So from a relapsing perspective, we can probably hold off on infusions up to a year. What we also know is that from a disability progression is it looks like dosing more frequently might have an effect on disability progression. And so because of that, then we are dosing a little bit more frequently than once a year, and we're going closer to the every 6-month infusion. There's actually a study starting up to look at even higher doses of CD20 to see if there's a better effect on disability progression from that. The question around how far can you push it then depends a little bit on people. So larger people get effectively less medicine, and so the B cells tend to come back sooner. Younger people's B cells tend to come back sooner. So there's a lot of different things that kind of come into it. I think the biggest thing is you want to stay at 6 months, for example, if you have active disease. So we've had a few patients that still had an MRI that just started drug. Maybe they did an MRI. There's a new lesion. Maybe it was a lesion from before they started drug. Those patients we don't want to push out. Those patients we're worried about them. We want to treat them much more aggressively. Those are the patients that we should try and stay on an every 6-month cycle. There's the patients who are on these drugs for convenience. It's 2 doses a year and I'm done. Whose risk of relapses is fairly low, and they would probably do really well on any other treatment. We just don't know. And so if it's somebody who's a little bit older and the risk of relapses goes down, those are the patients that, would probably do really well waiting 10, 12 months before their next infusion and just kind of holding off. Those are the patients we're a little bit more worried about as well, right? The older patient who's going to not maybe do as well with COVID. So if we can push those patients out, and so yeah, it's a little bit gray. I'm not giving any great sort of cutoffs or things like this, but those are the things that we try to weigh in when we're providing the guidance of, hey, you're somebody that needs to go every 6 months, and hey, you can go maybe 10, 12 months out. And so the average of waiting 2 months is kind of a nice, safe guidance for across the board so that we could start moving and having other people help us without having to start looking through the charts of, we see something like 3,500 patients at the university. We would not be able to do that really effectively. And so we had to push up something, and that was the idea around the 2 months, where it's really safe to do, but it's so, it's not going to probably have a lot of effect on things. And in the short term, they probably had some nice benefits across the system to try and do that. So within the cycle, again, not much difference. And 2 months is kind of a good number for pushing out the B cell infusions. But I wouldn't try to push out, everybody. I think we have to be aware of that. But again, if you've been stable, you're on, your MRIs haven't shown new lesions. Things have gone well with the infusions, all this kind of stuff. In that situation, it's very safe and very okay to push out those infusions several months. So I hope that helped answer that question, Kelsey.
Yes. Would you suggest any additional labs or blood tests at the 6-month mark to kind of determine that, or?
No, not necessarily. We are pretty good about trying to get some labs looking at the immune system, including antibody levels, just kind of broad antibody levels and things like that are the kind of, we look at the white cells in different counts. We sometimes have some issues getting labs done at other infusion centers. We're a little bit restricted by the insurance companies and where people can go, and sometimes just getting information back from the other infusion centers can be a little bit tough. But there's nothing extra that we would recommend at this time that would give us any additional information from what we already have. I think now with the capacity to test people with runny noses and other symptoms that are a little bit more concerning, I think we can start testing some of our patients and get a little bit better sense as to what's going around. I think one interesting number, if I can provide another hopeful piece, because I know I get a little bit paranoid when I go to the grocery store, is that even when you look at the people who are being tested, which is only hospitalized patients with bad respiratory infections, only about 15% of those patients are testing positive for COVID, meaning 85% of patients who have respiratory type things do not have COVID. So that person that just walked by you at the grocery store or sneezing or anything else like that, A, they shouldn't be at the grocery store, but B, probably don't have COVID and just probably have the flu or the cold or other things like this. And what we're seeing is it looks like the flu for the year might be dying out just because of social distancing, that colds are kind of getting a little bit less common and things like that. So the social distancing in the short term helps with COVID, but it helps with a lot of the other kind of respiratory type infections.
Awesome.
Do you have any other
Thank
questions,
you so
Kelsey?
much. I'm going to wrap it up now. And just if you had a question that did not get answered about a specific DMT, again, please talk to your neurologist. We aren't able to address really specific questions right now. So thank you guys for tuning in. Thank you, Dr. Alvarez, for the extra time today.
No, appreciate it. Thank you, everybody, for tuning in. And, yeah, please work with your neurologist. So thanks a lot.